Well, good morning, everybody who has joined. We are so excited to have this webinar today as part of what we are calling and what you may have heard about, which is our Mountain West Cancer Collaborative. And we're very excited today that we have three phenomenal women joining us to present about a topic that I think some of us know a lot about, some of us may not know enough about, and some of us may have many questions, especially as it pertains to some of the federal, state, and different changes as it relates to some new policies that have been enacted and spearheaded by the Biden Cancer Moonshot team, as well as American Cancer Society and other partners. I'd like to welcome our three presenters today, Miss Nabella Aspiras, Dr. Bonny Morris, and Miss Donna Branson from Huntsman Cancer Institute. So we'll get a little bit more info about them and their past work experience and a lot of the work that they are currently leading in their current roles. But I just wanted to start out by kind of setting the stage just very briefly for those who may be joining as the first webinar. This is just our second quarterly webinar since we've started this series, and we've really tried to pick topics that our community members have told us are important, topics that they may be working in their respective communities across the Mountain West, and thinking about how we can really be the convener for a lot of this work in the region and bring in the experts who can help answer some of the questions related to this topic. So we'll have the presentations, and then we'll have some time set aside for question and answer. And some of you have submitted questions in advance, and so we're excited to be able to answer some of those, and I'll help moderate that. So I'm just going to share my screen briefly before I turn the time over. Are all of you able to see this? Great. So just as part of setting the stage, I think everybody should be familiar, but with Huntsman Cancer Institute as the convener of this collaborative and webinar, we serve the entire Mountain West, the states of Idaho, Montana, Nevada, Utah, and Wyoming. The objectives of the webinar are here. I will not read them in length, but it is to be able to review some of the recent federal policies about patient navigation, discuss some of the challenges and opportunities with an emphasis on opportunities, and to really have a dialogue with some of the experts, as we've mentioned, from the Biden Cancer Moonshot, American Cancer Society, and our patient navigation program at Huntsman Cancer Institute. This is going to be our agenda. So we'll first hear from Nabella and Bonny, followed by Donna, and then we'll have time set aside, as I mentioned, for the Q&A. And briefly, for those, I think it's always important to set the stage and share our enduring mission of Huntsman Cancer Institute to understand cancer from its beginnings, use that knowledge in the creation and improvement of cancer treatments, to relieve the suffering of cancer patients, and to provide education about cancer risk prevention and care, as we also aspire with our vision of passionate individuals and teams delivering a cancer-free frontier through scientific discovery and human touch. This, as we've mentioned, is our area of service, which all of you have seen probably before, but this gives you an idea of what our aims are as we work together to really reduce the cancer burden across the area we serve. So if we mention that framing in any type of any time in this conversation, we're referring to the Mountain West. Our community outreach and engagement team is here. We are the conveners of the work, at least related to this specific webinar. And so you can contact us at any point as it relates to any of the things that we do in pursuit of collaboration. This is just to show a little bit of what the collaborative is, which is a space to foster bidirectional learning. We have newsletters, webinars, networking opportunities. We're not trying to take the place of a formal state cancer coalition, but we are trying to really have a resource sharing, networking, and leverage unique opportunities and perspectives here. If you're interested in signing up and you haven't been on the listserv, you can scan this QR code or reach out to our team and we can get you signed up. So that being said, it is my honor and pleasure to introduce two of our amazing speakers today, Miss Nabella Aspiras and Dr. Bonny Morris. I would just like to read a little bit of their bio so you get a little bit of understanding of their backgrounds and areas of expertise. So Ms. Nabella Aspiras serves as the Assistant Director for Engagement on the Biden Cancer Moonshot, which President and First Lady Biden reignited to mobilize a national effort to end cancer as we know it. In her role, she works with patients, caregivers, providers, academic institutions, foundations, and others to advance the ambitious goals of the Moonshot. Prior to joining the Moonshot team, she served as chief of staff at Mendel Al, a health tech startup leveraging clinical AI in the service of patients. She's a nurse by training, and her work has covered a wide variety of settings, from Sierra Leone during the 2015 Ebola outbreak to working on the front lines of the COVID response in New York City at the start of the pandemic. Nabella, thank you for being here, and welcome. And I'll start with you, and then we'll introduce Bonny after that.
Sounds good. I really appreciate that, Garrett. Quick sound check for everyone else on the call. I was having difficulty getting into the call, so I haven't been able to check anything. Can you hear me and see me? Terrific. Okay. I see people waving and really appreciate it. Well, Garrett, let me start by thanking you, Ashley Harrison, and also my co-presenter, Donna Branson, who really spearheaded involving the Cancer Moonshot in this important event. And that started, I want to say, about 2 months ago, when my boss, who is the deputy assistant to the president for the Cancer Moonshot, visited the Huntsman Cancer Center. So I just want to say thank you for letting me be part of this event and both engage with and hear from such a powerful group. I'm under the impression that many of the folks on this call are the boots on the ground, the really dedicated individuals who are working to ensure equitable access and care to the people who are impacted by cancer. And often, given your description of the communities that you serve, living in rural, frontier, and tribal communities. I know that when Dr. Carnival visited Huntsman Cancer Center in June, she connected with a patient navigator who may or may not be on this call, Lillian Mulatu. And I listened as Lillian described the barriers that her patients face, chief among them being accessing care, needing to travel long distances for care, and then language barriers as well. So I just want to also say thank you to the navigators and frontline staff who are on this call. Thank you for the work that you do every day to provide compassionate and quality care among especially vulnerable populations. I know that it's not easy work. It can be emotionally and physically draining, but it is imperative. And thanks to you all, people's lives are changed for the better. So I'm going to be talking about the Biden Cancer Moonshot and why we made expanding access to navigation services a priority. And then my wonderful colleague, Bonny, who is here with us from the American Cancer Society, will take us on a deeper dive of the navigation codes that can now be used to reimburse for navigation services. Our hope is that everyone on this call walks away from this presentation with information about how they can leverage the navigation work that the Biden-Harris administration is doing to bring reimbursement for these critical services back to your communities for the people, families, and communities that you serve. Before I jump in, I just want to orient this group to the Cancer Moonshot for those of you who may be less familiar. 2 years ago, the President and First Lady Jill Biden reignited the Cancer Moonshot with a singular mission to end cancer as we know it. Through the Biden Cancer Moonshot, we seek to build a world where, similar to your mission, cancer loses its power and a diagnosis is not a death sentence. So to accomplish this mission, the President and First Lady set 2 ambitious but achievable goals. The first is to cut today's age-adjusted death rate by at least 50% in the next 25 years, preventing more than 4 million cancer deaths by 2047. and to improve the experience of people living with and surviving cancer. To advance both of these goals, the president made expanding access to navigation services a priority because, as this group well knows, navigation has been shown to improve patient outcomes, decrease healthcare costs, and cut against health disparities. In fact, I would be remiss on this last point if I didn't remind everyone that the first patient navigation program in America was launched in the early 1990s by Dr. Harold Freeman here in Harlem, New York. I say here because I'm based out of New York. He implemented navigation as a strategy to improve outcomes in the marginalized communities where he provided care. We on the Cancer Moonshot have borrowed a definition of navigation services that the Oncology Navigation Standards of Professional Practice put together. We define cancer navigation as personalized assistance to patients, caregivers, and families to help identify and resolve barriers to high quality and timely care through care coordination and advocacy. Healthcare is a very real example of the intersectionality of issues of class, race, education, and access all come together to impact patient outcomes. Like Garrett said at the beginning, I was a nurse for many years, and I often felt like I was having to address so much more than just the ailment or illness in front of me. And we call these things that aren't medical in nature, but will impact medical outcomes, structural or social determinants of health. And navigation is absolutely critical to addressing unmet social determinants of health, like transportation needs and like food and housing insecurity. So given all of this, in his 2023 Unity Agenda, President Biden set the goal of making navigation services accessible to all Americans facing cancer. By accessible, what we mean is establishing a reimbursement strategy for paying for navigation. Prior to this, because there was no systematic way to pay for critical navigation services, navigation and navigators had to be paid by administrative or other budgets, which meant that if you didn't have that kind of overhead, you may not be able to provide navigation. And this left navigation out of reach for many, especially in lower resourced settings where we know that navigation is so necessary. So to advance the president's goal and with leadership from the First Lady, as of January 1st of this year, the Biden Cancer Moonshot delivered 6 insurance billing codes that can be used now to report navigation services for payment. Like I mentioned, Bonny is going to walk us through these codes, but at a very, very high level, we're talking about 6 codes. 2 are net new codes, meaning they didn't exist in billing and coding departments until this year, from the Centers for Medicaid and Medicare. These codes are called Principal Illness Navigation Codes, and they describe services focused on removing barriers to care, including care coordination, health education, patient self-advocacy skills, and facilitating access to community-based social services to address those unmet social determinants of health I mentioned earlier. On the commercial side, so Medicare is a government payer. On the commercial side, the Cancer Moonshot worked closely with the American Medical Association, who then issued updated guidance on the appropriate use of 4 CPT codes for principal care management. These codes can be used by all insurers to report clinical navigation services. Clinical navigation focuses on clinical care, coordination, and education, and is typically provided by clinical staff, including licensed clinical social workers and nurses. So all of that work to create the codes that could be used to reimburse for navigation happened in 2023. Now in 2024, we are doing a full court press to raise awareness and garner support for the adoption and implementation of these codes to scale navigation services across the country. At the beginning of this year, we convened a live Q&A session with experts from CMS and the American Medical Association to help advocates and frontline staff understand how these codes can be used and what they cover, which is critical to helping us, the Cancer Moonshot, understand gaps and opportunities as these codes are implemented. Then, as part of his unity agenda, which he announced at this year's State of the Union, the President and First Lady shared new commitments from 7 leading national and regional insurance companies, which cover more than 150 million Americans, so half of all Americans, who committed to reimbursing navigation services using these codes. This announcement was accompanied by 40 comprehensive cancer centers and community oncology practices who also committed to stepping up to bring these effective navigation services to their communities. At the end of March, the First Lady convened the executives from these health insurance companies, from community health plans, and from health plan professional societies at the White House to highlight their commitment to expanding access to navigation services to help patients and families navigate healthcare for treatment of cancer, as well as other serious illnesses. So here we are today, and through conversations like the one we're going to have today, we are trying to connect the dots so that organizations like Huntsman are aware that these critical navigation services they have been providing, even before there was a way to pay for them, can be reimbursed in order to sustain and scale robust navigation services. The new navigation codes do present revenue generating opportunities for healthcare practices, which, if we're talking in the specific example of nurse navigators, have historically been unable to charge for nursing care as an independent line item. This is just my math, but assuming that on average, a navigator sees around 100 patients and a mix of new and existing patients, by my math, annualized reimbursement for the PIN, Principal Illness Navigation, and PCM codes amounts to over $60,000 a year, which is very meaningful when you think about how that money could be used to offset or cover salaries. That said, adopting the codes and implementing them is not easy. Sometimes I like to say show of hands for anyone who's ever implemented anything related to the EHR. It's really difficult, but it is necessary in order to access that ROI. The things that healthcare systems have to consider are updating their operating systems, like I just mentioned, both the coding and billing software and also the EHR system so that frontline staff can document the navigation interventions. They have to think about training their staff, including coding and billing staff, on the correct use of the codes and how these codes will affect claims processing and reimbursement. And they have to train clinical staff in terms of documenting these services correctly. Additionally, you have to communicate with your payers so that they understand what's coming. And before any of that happens, you have to get executive sponsorship from hospital leadership. And none of that stuff is necessarily an easy lift, and I want to acknowledge that. But that's why we're having these conversations, is to think through all of those pieces together. And of course, once you've implemented the code, like you would do with any new effort, you have to monitor and evaluate utilization in order to understand if there are gaps. And most importantly, sorry, my computer is trying to participate with us. And most importantly, to evaluate patient outcomes, right? To make sure that that paying for navigation, that the navigation interventions that are being provided are improving their outcomes. That said, I think this work is really worth it because not only will it improve outcomes for patients and families impacted by cancer and other serious conditions, but it will help grow the field of navigation and the fundamental understanding that healthcare should meet patients where they are and not the other way around. So I've said a lot. Let me just summarize. First, President Biden made increasing access to navigation a priority because navigation has been shown to improve patient outcomes, reduce healthcare costs by preventing unnecessary utilization of the health system, and improve health equity by addressing deep-rooted issues of mistrust in the healthcare system. With leadership from the First Lady, as of January 1st of this year, the Biden Cancer Moonshot delivered 6 codes that can be used to report navigation services for payment. We think that this is a huge first step, but there is still work that needs to happen because high quality navigation needs to include navigation around screening and navigation around survivorship. But together, I think that we can finish the job that we've started to bring effective covered patient navigation to patients and communities across the country. Before I hand it back over to Bonnie, I want to make two quick plugs. The first is that the Centers for Medicaid and Medicare have issued a broad request for information on the almost 1-year-old principal illness navigation codes. Specifically, CMS is seeking comment on one, the types of auxiliary personnel who typically furnish navigation services, two, hearing more about community-based organizations and their collaborative work with billing practitioners to implement navigation services, and three, how practitioners in geographically isolated areas, for example, rural, tribal, and island communities, and otherwise underserved communities, are billing for principal illness navigation services. The 60-day comment period is open now. It closes on September 9th. But given how well positioned Huntsman is in this space, I hope that if you haven't already, that the folks on this call will come together to provide that valuable information back to CMS. That CMS, on a selfish personal note, for the Cancer Moonshot team, please visit our website. It's whitehouse.gov/cancer moonshot to get in touch with us. We want to hear from you about your navigation stories and how navigation reimbursement is working for you. So that's what I wanted to cover today. I know that we'll have time for question and answer after the presentations, and I am very much looking forward to it. But I'll stop there and hand it back to you, Garrett.
Annabella, I cannot thank you enough. That was probably the best layman's term, I think, of some very complicated work that you have been leading in collaboration with so many others. And very grateful. So thank you for setting the stage. Thank you for all of the work that you have done in collaboration with, the Bidens and so many others that are leading that effort. I would encourage those that are on the call to please make notes. And when it's time for the Q&A session, we will definitely have some time so that you can ask Bonnie and Annabella any of those questions as it relates to the work that you're doing, your organization, your health system, etc. It's now my pleasure to introduce Dr. Bonny Morris. Bonnie is a behavioral scientist with a clinical background as an oncology nurse and oncology nurse navigator. She is vice president of navigation at the American Cancer Society, where she leads the strategy, development, and implementation of these navigation programs, which includes ACS Cares, which we'll hear about, I'm sure, related to that app, and the ACS Lion, which is the leadership in oncology navigation certification, including some other capacity building grants, of which Huntsman has been a recipient of, which we're very grateful. And the collective goal, I'll just mention, of this work is to increase equitable access to high quality cancer care by providing strategic patient navigation funding, which I think is so critical, and ACS program support to patients, providers, and others. So with that, I will turn it over to you, Bonnie, and I will share my screen for the slides. And for the next 35 minutes or so, we'll have this conversation.
Perfect. Well, thank you so much, Garrett. Thank you, Annabella, for the wonderful discussion and framing. And I'm looking forward to then the Q&A at the end. I think this is just such a momentous time for navigation and how we can all come together to collectively advance health equity for all. And you can go on to the next slide and we'll get started. As Annabella discussed, the evidence is clear. We have 30 years of research implementation that shows that patient navigation enhances cancer screening rates, decreases time from diagnosis to treatment, increases quality of care and patient satisfaction, decreases healthcare utilization, and advances health equity. However, there has until recently not been a reliable pathway for sustainability of these services. Next slide. And, you know, what we've seen and what you all know is this has meant that there could be limited or no navigation services available. It's piecemeal. I remember when I was in an academic cancer center and having to apply for grant funding just to be able to sustain, you know, a 2-year position for a specific type like a breast navigator. So very piecemeal, resulting in wide variation of how the navigators are trained and those programs are implemented. And this then results in, you know, access that can be limited or inconsistently available for patients, thereby having poor care quality, outcomes, and exacerbated cancer disparities. Slide. And so we're so excited that now there is this new payer reimbursement opportunity brought through the Cancer Moonshot, where non-clinical navigation has the pathway for reimbursement, that we have the opportunity through our groups collectively and through those new programs that I'll talk about in a little bit with ACS Lion, to be able to champion these efforts, both for non-clinical navigation and clinical navigation, to support patients and caregivers. Next slide. As was discussed, so effective January 1st, 2024, CMS added these new reimbursement codes for health-related social needs. They include social determinants of health risk assessment, community health integration service, CHI services, principal illness navigation or PIN services. And then I'll focus on principal illness navigation services because this is a deeper dive, and I could probably talk about 3 hours on all of these, but we'll save that for another day. And I'll also touch on principal care management that originated in 2022. But as Annabella discussed, additional guidance has been provided to be able to support the implementation. So here are some key terms that we'll walk through, and you'll notice are consistently brought up throughout our conversation. So there's the billing practitioner. So this is a physician or other healthcare provider with a license to provide medical services and who can bill through Medicare. There's the auxiliary personnel, and these are team members who are then under the supervision of the practitioner. These are the ones providing the services. They could be an employee, they could be through an independent group like a community-based organization that's been contracted, and they're individuals who otherwise would not be able to independently bill for the services they provide. Then we hear the term incident to, and these are, this allows, the way the ruling was written, it allows these services to then be provided by these auxiliary personnel and then billed as part of that billing practitioner's overall billing services. They're incident to that provider's professional services in that they are integral to what is needed to support the treatment plan and overall services from the diagnosis or treatment. And then with general supervision, this is, you know, a service that's provided under this billing practitioner's overall direction, but it doesn't require their presence to be physically present while these services are provided. So we'll start first with principal care management, originating in 2022, that is for a patient with a complex chronic condition expected to last at least 3 months and places the patient at significant risk for higher healthcare utilization. It requires the creation or frequent updating of a care plan with adjustments that could be related to medication regimen or management due to complex comorbidities. Multiple specialties can bill, but it's focused on then with these codes, and I included the time per the first code, and then for the first 30 minutes, and then you can stack then additional 30 minutes after that. And it's geared towards those who are clinically licensed, who could then provide the services to then support the care management of these patients. So we're thinking more in terms of the clinical services provided by those who are providing clinical navigation. And I say it in that way because we also know that then clinical navigators, a nurse navigator, like what I once did, you know, and still have, you know, doing my heart for folks, but who can provide clinical services, but also to still provide that non-clinical support. And so I frame it that way so that when we go in, you can go to the next slide, we'll be able to talk more about that. So principal illness navigation, which is new then as of this year, are codes and payments for the non-clinical navigation in the treatment of a serious high-risk condition to address health-related social needs and other factors that influence treatment outcomes. These activities, as a navigator, you might scan through and think, okay, they're very, they cover what I would normally do: person-centered assessment, care coordination, contextualizing health education, building self-advocacy skills, facilitating behavioral change, promoting or providing social and emotional support, and then facilitating access to resources, all things that are critical in supporting the patient in their care journey, and things that we can now, as a nurse navigator or non-clinical patient navigator, receive reimbursement for these services. So for example, that nurse, as they're providing non-clinical services, they could have that be associated with PIN activities, and then the clinical activities be associated with PCM. Next slide. In terms of eligibility, patients are eligible under the CMS structure for the G codes enrolled in traditional Medicare, have a serious high-risk condition that's expected to last at least 3 months, placing the patient at a significant risk for functional decline, death, healthcare utilization, and requires a disease-specific care plan with ongoing management. Cancer was specifically mentioned in the final rule, and it also clarified that a mass likely to be cancer that's being worked up qualifies for eligibility. So it doesn't have to be fully diagnosed, but it's close. You're thinking that this is very likely and can initiate navigation services. These services are then provided by someone who is either certified or trained. This could be a patient navigator, a peer specialist. It's not specific to title, it's specific to the services provided. And then, as I said before, with auxiliary personnel, this is someone who could be employed by the practice, the health system, or a third party, and then provide services incident to that billing practitioner, where that practitioner's presence is not required. But the billing practitioner does still need to attest that the personnel and the patient are eligible for a PIN. So that means the billing practitioner would attest that the patient is eligible as per that blue box, and that the person providing services is eligible as of this red box. Next slide. So how does this get started? So before PIN services can begin, the billing practitioner has an initiating visit where they set the treatment plan. This could be an E&M visit, annual wellness visit, and then it establishes medical necessity for principal illness navigation, as well as developing the treatment plan and how the navigation services could support it. So it may or may not include a social determinants of health assessment, but I'll give an example later on where it shows a map of how that could work. Services can be provided in person, synchronously, asynchronously, telephonically. There have been lots of questions around this since it wasn't included in the telehealth schedule. And so we did ask we are in ACS, and ACS can in our comment letter for the request for information is asking CMS to confirm that it was intended to be provided across all modalities. The comments, the description that they included says this, but because of the amount of confusion, we wanted to make sure that that was clarified. Next slide. Payments through the G codes are as follows. So for the first 60 minutes, so here's the difference with PIN and PCM. PIN is for the first 60 minutes, PCM is 30 and 30. So just a slight difference there. And then the payments are different. There is patient cost sharing associated for those that don't have supplemental coverage to pick up that cost sharing component. And that's important then, because as we go to the next slide, we need to make sure that consent is included. So before PIN services can begin, there must be patient consent. It can be written or verbal. It needs to be documented within the medical record, explaining that cost sharing applies. And it could be obtained either by the auxiliary personnel at that first visit, or it could be obtained as the billing practitioner is talking about the care plan. And then it should be updated or obtained annually thereafter, or if the billing practitioner changes. Next slide. And so in terms of documentation, which is important because we want to make sure that then everything is tied together, the navigator should document in the medical record that the total time spent providing the services, how those activities, what those activities are, how they relate to the treatment plan, and then any SDOH needs that were identified. And then the billing provider would either attest to this or co-sign, depending on the structure of your system. How often can these be billed? There's no maximum set. So there's not a maximum set for the providing the services or a maximum duration. However, other than the 60 minutes, right? So there's not a maximum, there's a minimum. So if 60 minutes are not met in that first month, PIN isn't billed. It can then be billed the next month that at least 60 minutes of activities occur. It may be billed by different specialties simultaneously, but this is for different serious conditions. So you could have PIN services for oncology and for, treatment of diabetes management. So we want to make sure that is clear that it's not just for oncology, although oncology is a fantastic use case for it, that it can occur across other specialties, and that the activities can be provided by more than one certified or trained auxiliary personnel who can then contribute to those minutes. So for example, say we have Maria, who's a 68-year-old woman with newly diagnosed small cell lung cancer, who's meeting with her oncologist, Dr. Smith, and they're preparing Maria's treatment plan. Dr. Smith recommends that Maria meet with Paul, a trained peer navigator, to then fully assess and help address Maria's non-clinical needs before and during treatment. So say they have the initiating visit on July 5th. Dr. Smith and Maria meet, have their treatment planning discussion, navigation consent, and referral made to Paul. Paul then meets face-to-face with Maria on July 8th, conducts a person-centered assessment, provides referrals, and then assistance. All in all, that totals 45 minutes, and Paul documents that visit. Then on July 26th, Paul makes a phone call to Maria and follows up to see how things are going, assess any ongoing or new needs, and provides referral and assistance. And then all in all, that takes 20 minutes that Paul documents in the medical record. Then at the end of that month, Dr. Smith attests that CMS requirements were met for the patient and the auxiliary personnel. We see that that's more than 60 minutes for that month, so the practice can submit using the CPT codes and G codes associated and Dr. Smith's NPI number. So if we're thinking about then the broader picture of the different codes, how could this work? So you could have an initial medical visit where there's an SDOH assessment. It's determined there's not a serious medical illness involved. And so it's just SDOH needs that are critical to be addressed. And so could then shift over to CHI services, community health integration services. But then say there is a serious medical illness that is, we'll say it's cancer, then that could include PIN services for non-clinical navigation and PCM services for clinical navigation. And we all know then that saying it is one thing, but doing it is another. And so even with these new payments, we recognize that this will be challenging, and we want to be able to support that because we know that it's worth it for patients and caregivers. So we know that there are patient needs. And Garrett, I think that there might be animation. Thank you. Oh, can you go back one? Sorry, I made it tricky. I should have taken those out. So we know patient needs. So designing, say you're in a program where you didn't previously have navigation, but you want to make sure that you're designing the navigation program to meet that population's needs, or you're finally able to expand your services to better meet those needs. And so the opportunity has arisen to really define what those patient needs are. Next one. And so workforce challenges could include how you train or certify your auxiliary personnel based on CMS requirements, workflow challenges like making sure that everyone's on the same page operationally with having that initiating visit, establishing the eligibility and the timing of the navigation services. And then we love the EMR and how it can be challenging, right? When any changes are needed, or first determining what does that look like for documentation and ways that you can make it more efficient, like through smart phrases to be able to pull in text that you can then select and choose from, and then co-signing and attestation, and then cost, both for the system and on the patient that we want to make sure that we're continuing to consider and address. And so that's where the American Cancer Society has seen as, with 110 years of wins against cancer, 30 plus years of impact in navigation, and a White House charge to standardize and expand oncology patient navigation training, that we see this opportunity as a pathway for reimbursement that otherwise would not have afforded the way for us to be able to champion patient navigation in such a sustainable way, launching these at scale and fully, at a national level, being able to support training, credentialing, implementation support, and capacity building. And so, in alignment, we launched the ACS Leadership in Oncology Navigation Program, which in it has 3 pillars: guidance and education on implementing navigation best practices, training and credentialing for non-clinical patient navigation services, and then grants and funding support to health systems, practices, and individuals who are interested in providing sustainable, high quality navigation. So I'll focus on first the training credentialing program, which is available as of January 1st. It meets the CMS requirements for PIN reimbursement, is aligned to the oncology navigation standards for professional practice, and is designed for individuals who could be clinical or non-clinical, but who are providing non-clinical services. So we have several anchor partners who are listed here who have come together to say, yes, we're aligned in expanding high quality sustainable navigation and supporting and having their navigators go through this training program so that we can continue to expand navigation services for all. In terms of program structure, we designed the program to remove barriers to access, such as being able to complete it all online and being self-paced. There's no in-person requirement for either the training or the credentialing component. There are 10 interactive modules that the person moves through in a learning management system, which is Canvas. There is a final assessment that is remotely proctored with an 80% score to pass, and then that's how the person becomes credentialed. Re-credentialing and then continuing education is something we're deeply committed to and being able to continue to support, and will be aligned with CMS requirements. In this past fall, so almost a year ago, we conducted a pilot in collaboration with the ACS National Navigation Roundtable and others, so that we were engaging subject matter experts and other organizations in the curriculum development, feedback, participation, and to make sure that we're providing a needed support service for individuals. So 11 organizations, which included academic health systems, community-based practices all across the country, 80 participants from a diverse racial and ethnic backgrounds, clinical and non-clinical job titles with a range of years of experience. So those who are new to the field and also who've been in the field for quite some time, contributed to going through the curriculum, doing the knowledge checks and doing the final assessment to then give us feedback. And one of the interesting pieces I wanted to note was that very few, only 9 of the 80 individuals had any type of external formal education or training. The vast majority had job-based or organization-specific training. So we really see this as an opportunity to fill a gap in terms of national standardized training and credentialing for navigators. When we looked at the pilot results, we saw, yay, we met our mark. Our program significantly improved self-reported comprehension of those CMS required competencies that you see listed here that we know are so critical to navigation services, and that participants had high agreement scores. So for overall learning experience, program comprehension, that they'd recommend the program to others, and that it enhanced their professional experience. All to then, and if you can go to the next slide, because I'm a behavioral scientist and I like mixed methods, we included both quantitative and qualitative data to see that participants found the information engaging and informative without being overwhelming, that it had practical tools and resources that they could immediately then put into practice, which is something I think is so critical, not just, going through and reviewing a PowerPoint and then saying, okay, now what? But being able to say, okay, this is what I can do to significantly improve the care I'm providing for patients. That it was comprehensive and that it supported role delineation, particularly with clinical and non-clinical. In recognition that there is a program cost, so it's $495 per learner to access all of the training content, 2 attempts for the proctored final assessment, and then annual refresher courses. This program cost is then reinvested in other ACS navigation programs like the ACS National Navigation Roundtable, our capacity building grants domestically and globally, and ACS Cares. We created what is called ACS Equity Support. We had fun with the acronym, so it's ACS Lioness. To then, with the goal of having equitable program access for those who may otherwise have financial barriers in obtaining access to the program, so that it allows individuals to take the program at no cost. This past Q1 cycle, we were able to provide 51 organizations with equity support to train their entire navigation program to then through ACS Lion. And excitingly, the next application cycle is going to be opening in the next week. So August 30th through September 30th, there's a QR code. So please check that out if you're interested in applying for Lioness. So that was the training credentialing pillar of Lion. Now we'll move into the implementation support, something I'm incredibly excited about being able to offer, and how we can take something that is an incredible win and actually see it into practice. So we are developing and have been developing since January a resource library that includes webinars that we host through that platform and then record and archive so that you can access them at any point. There are some topics that are listed here, but I'll go into an example in the next slide. So right now we're running a collaboration with ASCO, where we have a 5-part webinar series that started in May. They're presented every other month. The recordings are available in the ACS Lion portal. And the next one is September 24th at noon Eastern. So I encourage everyone to attend that. We've talked about why navigation, innovative models. We'll be talking about clinical trial enrollment and electronic health records and how technology can be used to promote navigation. And then how to put it all together. How we'll hear from organizations and individuals who have started implementing these new billing codes and using them to then improve their navigation services. In May, we had our inaugural Building the Business Case for Navigation Bootcamp in collaboration with AONN. And that included really, it was 5 weeks of being able to understand how to develop a business case for professional navigation, including staffing models, team definitions, competencies, roles and responsibilities. Had weekly didactic sessions and then weekly Q&A sessions, office hours. There was no cost to participate. And from that, well, as part of that, we developed a business case toolkit for navigation, and we're able to get wonderful feedback from the business case bootcamp participants to then further iterate on that toolkit And we're really excited to be able to get additional feedback at the upcoming National Navigation Roundtable annual meeting, and then be able to have it nationally available, publicly available for anyone to be able to use. So we know that sometimes when you're pitching to your C-suite and you know that it's important, it just helps to be able to have those tools to be able to make that case. And we want to do that so that it's easier for folks. If you're interested in participating in the next boot camp, here's another QR code for you. And then the next professional education opportunity that we're launching is a financial navigation learning collaborative. That application cycle will be open September 3rd, I believe, beginning of September, so soon as well. And this will include, this is a smaller number. The boot camp we were amazed, 175 organizations that wanted to participate, each committing at least 3 individuals from different areas of their program. So we saw, hey, this is really important to a lot of people across the country. So that was a wonderful opportunity to engage hundreds of groups. This is going to be different because it's a smaller group. It'll be 15 to 20 organizations, and it'll run across a year versus 5 weeks. So it'll be focused on then groups coming together to implement best practices around reducing patient financial toxicity, have monthly, very structured sessions to help develop a process for identifying and addressing practice gaps, implementing a change practice, and measuring and demonstrating results. Again, applications will be open at the beginning of September, and you can find that available on our main cancer.org/lion page. I should have another QR code there, really. But actually, that's the QR code for accessing our cancer.org/lion page. From there, you can access the prior recordings from all of our webinars, upcoming sessions, tools, register for the Lion training, and then please feel free to reach out to us at acslion@cancer.org. Thank you.
Bonnie, wonderful presentation. We're so grateful for our partnership with the American Cancer Society and for all the work that you and the society have been leading, both from an ACS CAN perspective and through all of the pillars in which the organization is engaged. So thank you so much for that and for the detail. And it's now my pleasure to turn it over to, or I should say first, introduce Donna Branson with Huntsman Cancer Institute. So Donna is the Director of Patient and Public Education. She's worked in the field of cancer education for more than 30 years and has distinguished herself as a leader and mentor of professionals, myself included, at the local, state, and national levels. Under her leadership, she's led 3 programs: the G. Mitchell Morris Cancer Learning Center, providing accurate and compassionate cancer information to over 120,000 people. Those services are provided through phone, email, text, live chat, mail, and in person at our lending library. She also founded the patient navigation program at Huntsman Cancer Institute, as well as the community outreach and prevention education program as well. Her involvement has been extensive in a lot of different services. Her service, I should say, to different national organizations over the years, including the Cancer Patient Education Network, the Utah Cancer Action Network, and many other groups. So it's now my pleasure to introduce her, and she'll share a little bit more about the patient navigation programs here at Huntsman Cancer Institute and how we can be a service to those on the call and those in the region, especially those that have been diagnosed with cancer. So Donna, welcome.
Thank you. Thank you, Garrett. I'm excited to be here today. And before I start, I just wanted to give a big shout out to both Bonny and Nabella for the work that you're both doing. It's so important to those of us individually who know that your voices are speaking for all of us on a national level. So thank you so much. And Bonnie, we participated in your boot camp and it was wonderful. And I'm happy to report we have 2 ACS Lions certified navigators now. And our goal is to have our whole team receive that certification by the end of this year. So we're excited to have that. So anyway, so the objectives I was given was to highlight the structure, the key services, and impact of patient navigation services at HCI. So I'm going to talk about the main components of our navigation program and include how it helps patient overcome barriers and share some examples with you to illustrate its effectiveness. And then to provide a snapshot of how patient navigation is implemented across the 5 states. And I'll be discussing regional adaptations or challenges we've had in delivering services. And I'll end with a success story that we've had. So next slide, please. So our program in general, I wanted, Annabella talked about Dr. Harold Freeman, and he has been a big champion and guiding force in my career. And we were lucky enough to meet him at a conference this past May in Atlanta, the American Cancer Society. We had a patient navigation conference. And anyway, I'm happy to report at 91, he is still active and a driving force still. So anyway, amazing moment. But our programs have shared program goals. So those are to save lives from cancer, to eliminate barriers to care, and to ensure timely delivery of services. And our program staff is comprised of 5 FTEs, and we're all health educators by training, so we are non-clinical in terms of our navigators. And we have 4 FTEs that are dedicated to patient navigation, and then 1 FTE split among 3 of us dedicated to management of the program. And so for all of our programs together, our average caseload is 52 new patients a month, and we have a total caseload of 102 patients a month that are split among our navigators. And since we started our program, it started in 2009, so we're actually celebrating 15 years this year of having patient navigation services. We've navigated 3,575 new patients with a total caseload of 10,392 patients. And we do serve patients throughout the 5-state area that we serve. So next slide, thank you. So these are our 4 different programs, and I'll start with our oldest program, and then it goes to from left to right is our most newly established programs. So Lily Mulatto is our patient program manager, patient navigation program manager, and Lily has been with me for 13 years, I believe, 13 years now, and has done a wonderful job with our Spanish-speaking navigation program. And through this, we've navigated 258 new patients and had a caseload of 713 patients in the last 18 months. And we provide also adolescent and young adult navigation, and Carly Gray has done an amazing job of building this program up, and it was established in 2016. And we have a new staff member, Dawn Ritzwaller, who will be joining our team on Monday. So she hasn't started yet, but we're looking forward to welcoming her. And Carly has navigated 329 new patients and had a caseload of 528 patients in the last 18 months. Then we have our Frontier and Rural Patient Navigation Program that Amelia Tilleen is our patient navigator for that. This is a program that was established with grant funding from the American Cancer Society. We applied for their navigation capacity building initiative grant, and we're one of the 20 sites selected to get to do a patient navigation program. And with the funding we received, we were able to hire Amelia and work on a frontier rural program. And in that time, Amelia has navigated 281 new patients and had a caseload of 468 patients in the last 18 months. So it's just been incredibly well received. So, and so many patients are grateful for that. We also have an American Indian patient navigation program, and this is so American Indian navigation has been happening at Huntsman long before we're working on this. So there are two, Phyllis Nasi and Nathan Begay. They're in our community outreach and engagement office, and they have been providing these services for many years. And what we're doing now is we've got Mariella at 0.25 FTE to assist with patients that are receiving treatment, and she can rely on them. She's non-native, so she can rely on Nathan and Phyllis to get that to make sure the cultural components are being met. So, and as I mentioned, this is newly implemented. So far this year, in the last 6 months, Mariella has navigated 23 new patients and had a caseload of 31 patients. So next slide. So what are the barriers to care that we're seeing? So they vary depending on programs. So each of our programs have been set up uniquely. So our Spanish speaking, as I mentioned, is our longest running, and we've noticed language assistance is very important. So being able to meet with a navigator who speaks your same language has meant so much to the patients, and knowing that they have one point of contact to help them. They are facing issues of uninsured or they're underinsured and need assistance applying for financial aid. So that's 40 to 50% of our patients. They also have difficulty understanding the US healthcare system. And frankly, so do we. I know as a group, it's very complicated. And they come from countries where their healthcare system is not as complex. So that a good portion of education is provided to them to understand how it works here. We also have care coordination assistance and help with scheduling appointments. So I'll never forget, as we were originally setting up this program, just as one example, we had a patient who we found out was not coming back for treatment. So our patient navigator called and asked why, and he was a kidney cancer patient, and he had to receive multiple chemotherapies, and his first copay was $3,000. And he was like, I can't come back because I can't afford $3,000 each time. Well, what he didn't understand was his insurance, that was his maximum out of pocket. And so the other treatments were covered. So by the navigator explaining that to him, we were able to get him back in, and he completed all of his treatments. But that's just one small example of someone who may not have gone on with care because of a misunderstanding in terms of insurance. So we have many more examples, but I have less than 10 minutes. So, and then, so moving on to our adolescent and young adult program, this came about through a collaboration with our research teams. And so there's a big research component to this as well. So we have our, one of our researchers, Dr. Ann Kirchhoff, who does research into, she's trying to figure out the best way to explain insurance to AYA patients to help them navigate how to use that. We've talked about fertility issues, and the big problems that our AYAs face are financial assistance, insurance navigation, fertility, of course, is up at the top. Then the feeling of social isolation. They're among people who don't look like them. They're young, and they see a bunch of older people with chemo, and they feel very, very isolated. And then they struggle with mental health both during and after treatment. So next slide. And then with our frontier and rural patient navigation program, we are finding, of course, the biggest barriers are transportation, and these are nuanced. It's cost of transportation, the time that it takes to travel, and we really found out how much weather was a big factor in traveling through the mountains that we live in and getting to treatment when, people have had to postpone appointments due to the weather. And so we have financial concerns for lodging, lost wages, food, childcare, etc. And then also help with care coordination, trying to get as many appointments scheduled so that they're to reduce the amount of time they have to be here. And so we're very aware of that, Amelia is. And then we also here at Huntsman talk a lot about distance is a disparity. And we're really finding that that is true, and looking at ways to help our patients. So I won't read this whole thing, but patients from Montana travel the furthest to us with an average of 982 miles round trip, and that is a 15-hour drive time. And if you can imagine, if you're coming for multiple chemotherapies, you're talking about a large chunk of your life is going to be spent traveling for treatment or living in another city away from your social support. So they face a lot of challenges. So next slide. So in trying to pull together the metrics and show that we're successful, not just say through anecdotal evidence, we're so grateful to the grant that we got because ACS has required a set of metrics that we need to report. And so in establishing this grant, we worked with the EPIC team here to gather metrics and to produce monthly dashboards for us. And we now have a dashboard for each of our programs, which we're really excited about because we have real-time information now about who we're navigating, what they, where they're from, what their problems are, barriers. And the dashboard, for example, gives us information on no-show rates, which is important, psychosocial support, treatment compliance, diagnosis to treatment time, among other metrics that we're looking at. And I know I didn't have much time, so I'm just sharing one thing that we found, that since the beginning of our grant, we've seen the patient no-show rate decrease by 60%. And our goal was 50%. So we're really excited to see that number. And it's gone from, so luckily the no-show rate's pretty low anyway, but it's gone from 4.2% to 2.6%. So, and then finally, I'll just end with a patient story that our navigator, Amelia Tilleen, shared with me. So she said, when I introduced the Frontier Rural Navigation Program to a new patient scheduled for surgery at HCI, I discovered that he lived nearly 300 miles away, faced severe mobility issues, and could not travel by car due to health concerns. His caregiver, who was struggling with her own health issues, was unable to drive as well. And to further complicate things, he was also unable to travel by plane due to neurological concerns. These factors, compounded by financial instability and food insecurity, left the patient and his wife overwhelmed and discouraged. I further learned that they had recently moved to a small town where they had limited social support. I got to work addressing their many needs through a multifaceted approach. I began by tackling their financial concerns, coordinating with multiple clinics to seek funding to assist with living expenses through several grant applications. I provided patient gas gift cards purchased through ACS grant funds that were designated for rural patient support and gave them a comprehensive list of local food pantries. Further, I referred them to our in-house food pantry upon their arrival. I then connected them with our social worker to address their psychosocial needs. With my encouragement, the patient's wife contacted the neurologist to get clarity on flight restrictions, and we happily learned that the patient was cleared to fly. Despite initial complications, I managed to arrange for free round-trip flights through a volunteer pilot program and ground transportation via shuttle service and ride shares. Additionally, we secured lodging at ACS Hope Lodge and arranged for backup accommodations at our patient and family housing. Unfortunately, post-surgery, the patient experienced complications that necessitated an extended recovery period, causing renewed discouragement and worry for the patient and his wife. Although an in-person follow-up visit was strongly preferred by the provider, I successfully advocated for the telehealth appointment instead, allowing the patient to stay home, avoiding additional travel, and he began to receive necessary systemic treatment locally. The ACS Frontier Rural Navigation Grant was instrumental in facilitating comprehensive care for this patient, addressing emotional needs, overcoming their financial and logistical barriers, and ultimately ensuring that he received the critical and timely treatment required for his recovery. And so, next one. So I just want to say thank you. And I also want to give a shout out to our Cancer Learning Center team, because they are also providing navigation services, and they do this for the patients that don't qualify for our program. So there are many patients that we can't see, our patient navigators can't see. So our cancer information specialists are helping out with that as well. So thank you.
What a high note to end on with that story, Donna. Thank you. And Amelia, I know you're on the call as well, so thank you for that as well, because I know I think it really shows the complexity and the multiple interventions and activities and job responsibilities and the human, spirit at the end of it to be able to meet the needs of the patient. We have a guiding principle here of patient first here at Huntsman Cancer Institute, and I think that really embodies that. So with that, I want to invite Nabella, Donna, Bonny to now answer some of the questions that the participants on this call may have. So is there any questions? I know there's some really wonderful comments and gratitude in the chat here, but are there any questions from the audience? Yes. I will go with Leah first, and then we'll move on to Phyllis.
Good morning. My name is Leah Merchant. I work with the Montana Cancer Control Programs in Helena, Montana. I'm curious about the patient navigation aspect of identifying social determinants of health, and when those are identified, if there is guidance or if there are criteria of how to address those, or if addressing social determinants of health is just something that is determined as part of each clinic's workflow, if that's something that the LION program addresses, like how to identify community needs and resources. So if anyone has any information on that, I'd love to hear. Thank you.
I can get started with that one. So I have in one of our other slide decks where it goes through discussion for the SDOH assessment. I'm happy to send out that information for that particular code and the structure and requirements around that in terms of just practically doing it. ACS LION, the training credentialing program, does cover that. It covers community needs assessments, resource mapping, how you can then identify and then support patients through putting together a database or something like that to be able to connect people with resources. So happy to be able to share more information about that as well.
And I was going to say, Leah, it is integrated. So in our clinic intakes, there are questions that are asked on the social determinants of health. So that will go into the patient record so that anybody working on the case can see the different needs that a patient might have, and then we can steer the patient towards the right resources to help with those needs.
And Leah, we can share that the question, it's standardized for our health system here at Huntsman within the cancer hospital and the larger U Health
Mhm.
system. So
Thank
great
you.
question.
I'll also just add the CMS rule doesn't require a specific screening tool, so it could be the NCCN Distress Thermometer Problem List or other tool to be able to accomplish that.
Great question. Okay, we'll go to Phyllis and then to Dr. Portugal.
Good morning. These have been great presentations and great information. There we go. So I have two questions. With the patient cost sharing, when you ask that patient, are they going to be able to pay? Can they say no and still receive the service?
And so, Phyllis, I know that's something we've struggled with as we try to implement this, because we've provided navigation services free of charge all this time. So I think we're looking into ways that we could waive that copayment. And so if we don't want people to see that as a barrier to navigation services, and we know the people who need our help the most have the least resources. So that is, that's something we're going to make sure that they're not going to be denying for financial reasons. So.
Now, because I can see it as a deterrent to navigation services, definitely. And then the other question is, I know we have, a Spanish-speaking program. Often with the American Indian, Alaska Native, and Native Hawaiian patients, we need to have translators. And they at one time were free, but most of the people who we touch base with now charge. So how does that work? Do we pay for them the $60 for that translation service and then get reimbursed for it?
I guess I can try and answer that question too for our system, but it is my understanding, first of all, Mariella hasn't dealt with anybody who needed language assistance services. And if we did, I know that it's part of University Healthcare's and Huntsman Cancer Institute's policy to pay for those services. So whether it's with an iPad translator or someone on the phone, that is paid for by the system, by the healthcare system.
Yeah, the reason why I bring it up is Mariella just got a request for someone and came to us. So, and
okay.
the translator, we have one, but they cost and we haven't used them. I didn't know that we were able to pay for them now.
Yes.
Okay. Thank you.
Could I also just add, from the cost sharing perspective, echoing what Donna has said, that we've heard from other organizations working to try to be able to waive that for their patients. We're also advocating in our request for information to CMS to have them further review their ability to be able to focus on that, as well as wanting to highlight that there are resources available to then help patients with those copays, like the Patient Advocate Foundation, that then the navigators could utilize to help the patient be able to still receive those services.
And just to piggyback off of that, first of all, Phyllis, great point. I have heard from several healthcare systems that they are worried about the cost sharing as being a blocker for patients accepting that care. I think always there's the do the right thing, right? Like, you're going to get the patients the resources that they need for them to complete their treatment. We all want to do that. What I have also seen, though, from the two health systems that were able to go live with the codes in Q1 of this year, they did a risk stratified approach. I am so sorry that my computer thinks that they are part of this talk. That beeping is very annoying. I don't know if you can hear it. They did a risk stratified approach in terms of how they executed their resources against their patient need. In the first 6 months of using the PIN codes, none of their patients had yet received a bill because their deductibles had already been met through their kind of complex health pictures. So I don't think you can bet on that, right? Like I would use language in my script around, you may receive a bill, but this care is so important that we're highly encouraging it. But in the first 6 months of use at one of the centers that I've been working with to collect their early data on the codes, their patients had not received a bill.
You see, because it's very important between the Indian Health Service and the tribal 638s, trying to implement that copay, which does not exist within the type of healthcare system that they have. I'm wondering about that, because we would serve them anyway, no matter what, because that is what the program has always been. But what the reimbursement system does for us is helps us implement the patient navigation services also at the tribal level and in the clinics, so that they know what is going on. They know their patient is here, and we don't lose them after discharge, because that's what's been happening. Once they're discharged, they drop off the system. Thank
Great.
you.
Phyllis, thank you. Dr. Portugal.
Thanks. Well, I work in Alliance Community Services, and we have a survivors group, Triunfadoras, which actually Lily Mulato was already presented to the group because they wanted to know what a navigation does. And it was very interesting to realize how much our patients from the speaking Spanish group is a little bit disconnected because they don't know that the bridge is already there with the patient navigation system. So it was amazing, not only for them, but for us to know that our community health workers, once they are accredited, if they go through the LION program, can become patient navigators. But we're a nonprofit. So how would it work for a nonprofit community-based organization in this plan to do the billing? Because we don't use an electronic medical record. We're not healthcare providers. So how do we build this to Medicaid? Or also, how can we get more involved directly with the clinician part of the navigation?
I can try and go first. So the way that the principal illness navigation rule is written is that the services can be provided by auxiliary personnel who are employed at a community-based organization. That said, the community-based organization needs to have a contractual agreement with the billing practitioner. So the codes essentially can't be dropped by any system other than the system where the patient is receiving care. So if you have an arrangement with a clinic that is overseen by a physician who also oversees care of that patient, there should be a way for both organizations to work together to essentially submit for the reimbursement and have that payment go to the organization that provided the care, albeit through the billing practitioner. That was one of the points that CMS is seeking comment on. I don't know if this is a good or bad thing, but after nearly a decade at bedside, I had never worked with a community health worker directly. It's because the systems are complementary, but they don't always interact. And yet the PIN services, community health workers are very well positioned to provide that care. So this is a moment for the healthcare system to learn how to put those two pieces together so that both groups can provide that service, and that the organization, the community-based organization who employs those individuals, can also see the return on investment, can see the money essentially, so that they can continue to provide and scale their navigation services. So sorry, that was a long-winded answer of saying through a contract, it is allowable that these services being provided by a community-based organization could see the reimbursement that is submitted by the billing practitioner.
Thank you.
That's a great question, Dr. Portugal, because I know that's something that we as a health system, as a cancer hospital with Donna, we're still figuring out from our health system how to implement these codes. It's very complicated, very complex. And then what opportunities after we've, figured that out, can we engage, that additional contractual agreement with some of these other organizations like Alliance Community Services and other groups that are employing community health workers. So I think there will be a lot of discussion in the future about that.
I'll be in touch.
Yes. Yeah, absolutely.
Thanks.
And to go along, sorry, before we have other questions, because I have a question too. So we are struggling to get the PIN code put in, and I was just told by our university healthcare billing office that because we are, because we're a hospital system and not an office setting, that we can't use those codes. And so Bonnie or Annabella, I would love to reach out to you and figure out, because that's not my understanding. And
Correct.
but
what you're experiencing there was a lot of misunderstanding around this when the codes first hit. The codes you can use the codes in inpatient or non-facility settings. The rates of reimbursement differ slightly, and CMS has adjusted for that, but the codes can be used in both settings. So let me,
I just put the FAQ in the chat. Yep.
Thank you.
Okay.
I was like, what is the best way for you to get the document that explains this to your billing department? And Bonnie on the spot.
Bonnie on the spot. Thank you. So I will, because I knew through all of the boot camps and I've been looking through the documents, but thank you. Okay. Sorry.
Wonderful. Well, this hour and a half has passed rapidly and very fast. And I would just like to thank you, Annabella and Bonnie and Donna, for your wonderful presentations. They were so informative and really captured, I think, the spirit of navigation and where we're headed and the opportunity that so many of us have, including, our own cancer center. So this has been recorded. We will share this recording with our network for those who are interested. I know that was one of the questions in the chat as well. And we hope and we know that you guys will continue to be a resource for not only for us, but for all of those that are on the call, and anything we can do to help facilitate that, we are willing to do and happy to do, because we are so invested in this work as well. So I hope everyone has a great rest of your day. And thank you again for all of this presentation and engagement.
Thank you.
Thank you so much.
Thank you so
everyone.
much.
Thank you.